This explainer is based on the literature review, Cervicogenic Dizziness, Diagnosis and Management, Cervical-Vestibular Interaction and Combined Therapy, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com.
Welcome back to the series. Today, we're zeroing in on the cervical assessment battery. Think about it. What exactly turns a plausible, maybe even a bit vague patient history into an absolutely confident cervicogenic diagnosis? Well, let's break it down.
Here's our roadmap for today. First, the confident diagnosis profile. Then we'll hit Phase 1, proprioceptive tests, followed by Phase 2, mechanical tests. And finally, we'll wrap up by synthesizing the clinical profile.
Section 1. Confident diagnosis, the clinical profile. So we're starting with the core clinical challenge. What specific elements transform a patient's story into a highly confident diagnosis?
It all boils down to the cervical assessment battery. We're looking at 4 specific tests, applied sequentially. The JPE test, the SMOR test, cervical range of motion, and segmental palpation. Honestly, mastering these 4 building blocks is exactly what separates clinical guesswork from total precision.
This breakdown brilliantly illustrates why we need these targeted tests. The differences are pretty stark. Cervicogenic dizziness usually presents as a feeling of unsteadiness or floating that's directly triggered by neck movement or posture. And crucially, this happens alongside a completely normal vestibular workup. Now, contrast that with true vestibular pathology, which typically gives you actual spinning vertigo, triggered by head impulses and confirmed by abnormal VHIT or caloric testing.
Section 2. Proprioceptive tests. Phase 1 assessment. Let's move straight into Phase 1, focusing squarely on oculomotor and proprioceptive integration.
First up is the JPE, or Joint Position Error Test. This one's an incredibly sensitive measure of a cervical proprioceptive deficit. The setup is simple, but really powerful. You have the patient wear a helmet with a mounted laser pointer. They sit facing a target on a wall, actively rotate their head 45 degrees, and then they try to return to neutral blind, meaning with their eyes closed.
So the crucial takeaway here is the number 5. An error greater than 5 centimeters at the wall, which is roughly equivalent to a 5-degree angle, is considered abnormal and reproducible. This essentially proves that those deep cervical muscles are sending scrambled positional data straight to the brain. Now, what's genuinely fascinating about this is that the JP isn't just a diagnostic tool. It actually doubles as your outcome measure. It's literally the single most useful objective sign to track your patient's recovery over time. Why? Because that error margin will tangibly improve as you do proprioceptive retraining.
The second test in Phase 1 is SMOR, or the Smooth Pursuit Neck Torsion Test. Normally, if someone visually pursues a slowly moving target, it's perfectly smooth. But in cervicogenic cases, if you have the patient track a moving target while you rotate their trunk under a fixed head position, you're going to see these little catch-up saccades during torsion. And here's the kicker: those erratic eye movements are completely absent when the trunk is just resting in neutral.
Section 3. Mechanical Tests, Phase 2 Assessment. Transitioning into the second phase, we're looking at the somatic evidence of cervical dysfunction.
Here, you'll run through a standard cervical range of motion screen. You want to thoroughly assess both the active and passive ranges, checking flexion, extension, lateral flexion, and rotation. Be sure to record the actual degrees. But the real key? You're noting any restricted rotation, or, even more importantly, any pain reproduction during these movements. That's what really builds your positive cervical profile.
Next up, we move to palpation. For this, you need to maintain a hyperfocus on the upper cervical spine, specifically targeting that joint complex from the occiput down to C3. This specific region is super dense with the cervical proprioceptors that constantly feed into the central postural network.
And that brings us to the absolute holy grail of the mechanical assessment. If palpating those specific upper cervical segments exactly reproduces your patient's dizziness or unsteadiness, well, you've just found a massive clinical clue. In fact, tender points that reproduce a patient's symptoms, that is the single strongest positive finding you can uncover in the clinic, hands down.
Section 4. Synthesizing profile, the clinical picture. Okay, so we've got our 4 assessment pieces. Now, let's pull all this data together into a clear, actionable diagnosis.
Here's the entire battery mapped out all together. We're talking JPG testing over 5 degrees, a positive SMOR test, range of motion deficits, and upper cervical palpation tenderness.
Viewing all of these as one complete package is exactly what gives us our definitive answer.
So the golden rule of thumb for a confident diagnosis formula is this. You need 2 or more positive tests from this cervical battery in a patient who also has a perfectly normal vestibular workup, meaning their VHIT and caloric tests come back normal. It's all about the combination. You're ruling out the inner ear, and you're ruling in the neck.
Before you even think about wrapping up session 1, it is absolutely mandatory to document 3 specific baseline metrics. Get the JPAID in degrees, the Neck Disability Index, and a Dizziness Visual Analogous Scale. You need these baselines so you can objectively measure the patient's response over that crucial 8 to 12-week recovery window. I want to leave you with a highly critical thought. What happens if your patient simply isn't responding by week 6? Well, always be prepared to rescreen for vestibular hypofunction or a vestibular migraine at that 6-week mark. You see, true cervicogenic dizziness is rarely isolated. It's almost always part of a dual pathology, and the dominant driver can actually shift as the initial inflammation settles down.
In Explainer 3 of this series, we're going to cover combined manual therapy plus vestibular exercise, including the dose, the progression, and the adherence levers that really drive that 8 to 12-week recovery. For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this series, head over to AustralianDizzinessClinics.com. Also, please don't forget to subscribe to the channel and leave a rating to help support the series. See you next time.